Hey guys, welcome back. We're going to continue our hematology discussion with another very important topic, and that is none other than your lymphomas. And I know, like every single topic in hemato-oncology is actually important because those topics don't really give you the basics of understanding. At the same time, they are per se very important for exams. If you know the entire hemato-oncology, like you can easily answer like 10 to 20% of the questions, or even more than that. That's why like lymphoma discussion is also going to be little extensive, but it's required at this point of time. We are predominantly going to talk about the B cell lymphomas rather than the T cell lymphomas because the questions on T cell lymphomas will be sparse. It will be very little. You don't get that much questions on T cell lymphomas. But nevertheless, we're going to have a little bit of discussion on the T cell lymphomas at the end of the section as well. First, there are two major types of lymphomas that we know. These are nothing but Hodgkin and non-Hodgkin lymphomas. And first, we need to know the differences between the Hodgkin and the non-Hodgkin lymphoma. So, right from the epidemiology, let us start. So you all know that the incidence of non-Hodgkin lymphoma is steadily increasing because of various reasons like infections, but the incidence of Hodgkin lymphoma is stable over the last like 20-30 years. The incidence has not changed in the sense it's not increased or it's not decreased. The cell type that's going to produce the lymphomas are going to be most commonly the B cell. In fact, the Hodgkin lymphoma is produced by the so-called crippled B cell in the germinal center, whereas non-Hodgkin lymphomas are going to be either B cell NHLs or T cell NHLs. But as I said, the B cell NHLs are going to be the most common. It's going to be 85% of all the NHLs. T cell NHLs contribute to 15%. What is the average age at the time of diagnosis? Hodgkin lymphoma will be usually diagnosed in the middle age group, childhood or the middle age group. Around 30 years is the average median age. But when it comes to non-Hodgkin lymphoma, most of the people will be elderly, like more than 60 years. And what about the lymph node involvement? Hodgkin lymphoma tend to typically involve the supradiaphragmatic nodes. Supradiaphragmatic nodes, and they are going to have a orderly and a kind of a contiguous spread. Orderly and a contiguous spread. They won't involve the lymph nodes in a very haphazard manner. Orderly and contiguous spread. Whereas non-Hodgkin lymphoma is something that can involve any nodes, anywhere. So it doesn't need not only involve the supradiaphragmatic or infradiaphragmatic nodes, it can involve anywhere, both supra as well as infradiaphragmatic. But the involvement will be very haphazard and it can have a non-contiguous spread, not an orderly spread like Hodgkin lymphoma. And what about extranodal disease? Extranodal disease per se is very rare in the setting of Hodgkin lymphoma, but it's extremely common in the setting of non-Hodgkin lymphoma. Coming to the other clinical features, B symptoms are actually quite common in Hodgkin compared to non-Hodgkin. What are the B symptoms? These are TB-like symptoms like fever, which will be typically a low-grade fever. Hodgkin lymphoma tend to produce a characteristic type of fever called as Bell-Epstein kind of a fever. But nevertheless, so low-grade fever, weight loss, malaise, anorexia, fatigue. So these are the so-called B symptoms. Night sweats. These are the so-called B symptoms, and it can be seen in 40% of patients with Hodgkin lymphoma, but it's seen only in 20% of patients with non-Hodgkin lymphoma. But presence of B symptoms generally indicate high tumor burden in the setting of non-Hodgkin lymphomas. And interestingly, pruritus is a very important symptom in the setting of Hodgkin lymphoma. That is probably because of mast cell activation causing histamine release, and that is seen in approximately 10 to 15% of the patients. So 1/6 or 1/10 of the patients can have significant pruritus. That is characteristic of Hodgkin lymphoma, and it is really not seen in patients with non-Hodgkin lymphoma. And as I said, patients with Hodgkin lymphoma can have a recurrent fever called as Bell-Epstein kind of a fever. And interestingly, alcohol can increase the pain in the lymph nodes, and that also occurs in 10 to 15% of the patients. So alcohol can increase pain. Consumption of alcohol can increase pain in the lymph nodes. When it comes to non-Hodgkin lymphoma, the symptoms are going to be very much variable, and it's going to depend on the site of involvement where they can produce some local side effects, or they can produce symptoms due to like burden of the disease itself. It depends on so many things, but most of the patients are going to come because of mass effects, plus or minus B symptoms. That's how they're going to present. And what is the defining feature of Hodgkin lymphoma? It's the Reed-Sternberg cells. We know in the biopsy, in the histopathology, you're going to see something called as Reed-Sternberg cells in a very characteristic cellular milieu. We'll talk about that. It's going to have a pleomorphic background, and that is characteristic of your Hodgkin lymphoma. Whereas in non-Hodgkin lymphoma, you're not going to see any Reed-Sternberg cells whatsoever. And the histological picture will completely depend on the type of the non-Hodgkin lymphoma. In the B-cell lymphoma itself, we have plenty of different types of NHLs, and the histological picture will completely depend on what is the type of non-Hodgkin lymphoma. and most of them will be present with early stage when it comes to Hodgkin lymphoma. More than 80% of them will be presenting in stage 1 or stage 2 disease, early stage disease. But most of them, when it comes to non-Hodgkin lymphoma, are going to have advanced stage disease, that is stage 3 or stage 4. And overall, what is going to be the management? Management will be ABVD regime plus or minus radiotherapy. That's the standard therapy for most of the patients with Hodgkin lymphoma. A stands for adriamycin, B stands for bleomycin, V stands for vincristine, and D stands for dacarbazine. So that is ABVD regime plus or minus radiotherapy. Commonly, what kind of radiotherapy that we're going to use is involved-site radiotherapy. So that is the current standard of care. We don't go for the inverted Y field or mantle field regime. So those are very hazardous form of radiotherapy with high risk of thyroid and breast cancers in the future. So that's the reason why we are going to go for something called as involved-site radiotherapy alone. So ABVD regime along with plus or minus involved-site radiotherapy is the standard management with regards to Hodgkin lymphoma. When it comes to non-Hodgkin lymphoma, the management is going to be highly variable. It's going to be based on type. So we're going to use a regime called as R-CHOP regime, or you can use R-CVP regime. We'll talk about what are those things later on. But the standardized regime is going to be R-CHOP regime plus or minus radiotherapy. For most aggressive cancers in the setting of non-Hodgkin lymphoma, we just go for R-CHOP regime. And some indolent tumors like follicular lymphoma can be just observed if it doesn't create any problem. So indolent neoplasms can be just observed without treating them at all. But aggressive cancers has to be treated. So usual treatment for aggressive cancers will be R-CHOP or probably R-CVP regime. So what is R-CHOP? R stands for rituximab. Generally, they are going to express CD20, so rituximab will be added. C stands for cyclophosphamide. H stands for hydroxydaunorubicin, that is nothing but daunorubicin. O stands for oncovin, that is vincristine, and P stands for prednisolone. So this is the standardized regime as far as your non-Hodgkin lymphoma is concerned. So what about the prognosis? So most of the cases of Hodgkin lymphoma is curable, more than 80% cure rate, so which is good thing. And when it comes to non-Hodgkin lymphoma, the prognosis is highly variable and most of them are incurable, especially when it comes to your advanced stage indolent neoplasms. Surprisingly, the aggressive neoplasms are going to have a high cure rate. But the so-called indolent neoplasms like follicular lymphoma, mantle cell lymphoma, these are the neoplasms that are basically incurable. You cannot cure them. So you can control them, but you cannot cure them. And what are going to be the B symptoms? We are talking about B symptoms, right? So what are B symptoms? Number one, fever. Generally, it will be low-grade fever, like more than 38 degrees Celsius, that's it. You can have drenching sweats, especially night sweats, and they can have significant loss of weight, like more than 10% in the last 6 months. So whenever you suspect a lymphoma, how to obtain a lymph node specimen? Remember, excision biopsy is always better than your FNAC. FNAC is often inadequate. If you can't do an excision biopsy because of some reason, then at least do a true cut biopsy. But biopsy has to be done. Some form of biopsy has to be done. FNAC is almost always going to be inadequate because the lymph node architecture will not be visualized properly in FNAC. You know that in FNAC you are just aspirating, so the lymph node architecture as such will not be visualized. So know whether it's a lymphoma or not, you need to know the lymph node architecture. Along with that, you need to know the background. Background is also very important. That's the reason why it's better to always go for some form of biopsy. Excision biopsy is the best, if not possible, at least a true cut biopsy. And what you're going to do, apart from doing histopathological examination, you also have to send the sample for flow cytometry to look for the CD markers. And you also have to send the sample for cytogenetics. In case if you suspect a cancer, you need to know the cytogenetic abnormality, which can be vital in the setting of non-Hodgkin lymphoma especially. And what about FDG PET? FDG PET is a very important investigation. So that is fluorodeoxyglucose PET. It's very useful for staging purposes because most of the lymphomas are PET avid. Most of the lymphomas are PET avid or FDG avid, except few lymphomas. Certain lymphomas may not be PET avid. We'll talk about that later on as well. But most of the lymphomas, especially Hodgkin lymphoma, will be extremely FDG avid. So definitely you can stage them and you can even use them for monitoring after starting therapy. And PET can also detect bone marrow involvement. So no longer routine bone marrow aspiration is indicated in the setting of lymphomas. That is because PET itself can detect bone marrow involvement. So bone marrow aspiration is something that we don't do routinely in current practice. Unless and until you suspect a non-PET avid tumor with significant bone marrow involvement or bone marrow infiltration, you can do bone marrow aspiration. Otherwise, PET itself is enough most of the times. And except in certain T-cell lymphomas where PET will not be very reliable. Apart from that, you can rely on PET for looking at the bone marrow involvement as well. So that's the reason PET has so much of advantages. And PET, apart from that, can visualize the liver and spleen involvement better than the CT scan. CT scan can just show the hepatomegaly or splenomegaly, but PET is the one that's going to tell you the actual involvement of the liver and spleen by the cancer cells and the actual tumor burden in these areas. So what are the examples of lymphomas that are not FDG aware? So you have to be careful with these lymphomas, not FDG aware. Marginal zone lymphomas, famously called as maltomas, and CLLs and SLLs. That is nothing but chronic lymphocytic leukemia, small lymphocytic lymphoma. In these situations, you have to be little careful because these tumors are not FDG aware. Hodgkin lymphoma tends to have a kind of a bimodal distribution. Everyone knows that. And the first peak is the major peak that's going to occur at 15 to 35 years of age in the younger population. And the second peak is a minor peak at older age, like more than 50 years of age. And there is some definitive role of Epstein-Barr virus in some cases, not in all cases though. In some histological subtypes of classic Hodgkin lymphoma, EBV can play a role. Otherwise, in other subtypes, EBV doesn't have a role. So how can you classify Hodgkin lymphoma? You can classify into two varieties. Basically, one is going to be the classic Hodgkin lymphoma and second is the NLPHL, that is nodular lymphocyte predominant Hodgkin lymphoma. As you can notice, that classic Hodgkin lymphoma is the most common 95% of the times. NLPHL is not very common, going to occur in only 5% of the cases. So what is the typical tumor cell in the setting of classic Hodgkin lymphoma? It's the classic Reed-Steinberg cell. If you look at the overall neoplastic cell population, it's going to be less than 1%. That's why you have to actually search for this tumor cell. It's not easy to find the tumor cell. You have to search carefully because there will be a background of non-neoplastic inflammatory cells and these cells will be somewhere in the inflammatory background. So that's why sometimes for beginners it may be little tricky or difficult to find out this classic Reed-Steinberg cells in the background of all these inflammatory cells. And how Reed-Steinberg cell is going to look like? It's going to have a characteristic that owl's eye appearance. They're going to have a kind of a bilobe nucleus with prominent nucleoli and surrounding clear space, that is perinuclear clearing. So bilobe nucleus, prominent nucleoli with surrounding clear space. That is typical Reed-Steinberg cell and it's going to have a kind of a owl's eye appearance. I'll show the image in a while. In NLPHL variety, that is nodular lymphocyte predominant Hodgkin lymphoma type, we are going to see only variant Reed-Steinberg cells. These are also referred to as popcorn cells or otherwise called as lymphohistiocytic cells. These are correct names. Lymphohistiocytic cells, otherwise called as popcorn cells. These are also called as variant Reed-Steinberg cell. You don't see the classic Reed-Steinberg cell in NLPHL cases. What about EBV association? EBV association is quite common in the setting of classic Hodgkin lymphoma, that too in approximately 50%. Only two subtypes, your mixed cellularity type and probably your lymphocyte rich type sometimes can have some good EBV association. Even your nodular sclerosing type has decent EBV association. But apart from that, your lymphocyte poor type usually does not have EBV association. Rather, it tends to have HIV association. We'll talk about that. So, EBV association is common in certain histological subtypes in approximately 50% cases overall. But EBV association is extremely rare in the setting of nodular lymphocyte predominant Hodgkin lymphoma. When you look at the CD markers, this is going to give a lot of clue in exam. So, classic varieties will be positive for CD15 and 30 and they are going to test negative for CD20. That's why you cannot use rituximab. Rituximab cannot be used in the setting of classic Hodgkin lymphoma. In fact, for non-Hodgkin lymphoma, rituximab is a very, very important part of therapy. But for Hodgkin lymphoma, rituximab is not an important part of therapy because most of the case of classic Hodgkin lymphoma will not express CD20 at all. So, how can you give an anti-CD20 monoclonal antibody? But you can make use of anti-CD30 monoclonal antibody like brentuximab vedotin. It's actually an antibody drug conjugate. We'll talk about that. Because they express high levels of CD30, you can use brentuximab vedotin, which is actually an antibody drug conjugate targeted against CD30 molecules. And in most cases of classic Hodgkin lymphoma, you tend to see amplification of the so-called 9p41 region, which is going to amplify the PDL1, PDL2 and JAK expression. So that's why in advanced case of classic Hodgkin lymphoma, you can make use of your immune checkpoint inhibitors, ICIs as well like pembrolizumab, that can be used in advanced stages of classic Hodgkin lymphoma or refractory relapsed cases. So what about your NLPHL cases? NLPHL cases will test positive for CD20. That's why you can use rituximab here. But they are going to test negative for CD15 and CD30, which means you cannot use brentuximab vedotin in most of these cases. What will be the prognosis of classic Hodgkin lymphoma? Prognosis is quite variable depending on the histological subtype and so many other cytogenetic markers. but NLPHL cases are going to have an excellent prognosis. In fact, among all the cases of Hodgkin lymphoma, NLPHL is the one that's going to have the excellent and the best prognosis. And in exam, they can also ask something called as Reed-Steinberg-like cells, where you're going to see RS-like cells or RS-like appearing cells in infectious mononucleosis. Infectious mononucleosis is also due to Epstein-Barr virus, right? So you can understand they can produce Reed-Steinberg-like cells. And EBV-associated mucocutaneous ulcers, and another problem, EBV-associated mucocutaneous ulcers. But here the biopsy will be taken from the ulcers, right, not from the lymph nodes. That itself is going to tell the problem is something different. EBV-associated mucocutaneous ulcers can result in RS-like cells in that area. And certain non-Hodgkin lymphomas also tend to produce RS-like cells. They are not RS cells, but RS-like cells. For example, mediastinal large B-cell lymphoma, and we have something called angioimmunoblastic T-cell lymphoma. We'll talk about those things later on, maybe if we have time. So, mediastinal B-cell lymphoma and angioimmunoblastic T-cell lymphoma also can produce RS-like cells, and a drug can produce RS-like cells, that is phenytoin-induced lymphadenopathy. Most of the time, phenytoin causes something called as pseudo-lymphomas. You have studied in medicine that phenytoin produces something called as pseudo-lymphoma. So, phenytoin-induced lymphadenopathy, if you biopsy from that node, you can also show RS-like cells, and certain solid organ cancers, very, very rarely, certain solid organ cancers also can show RS-like cells. What are the histological subtypes of your classic Hodgkin lymphoma? Number 1, nodular sclerosing type. Number 2, we have something called as mixed cellularity type. Number 3, we have lymphocyte rich type. Number 4, you have lymphocyte depleted type. So, nodular sclerosing type is the most common histological subtype, and it is commonly seen in females and young adults. Other subtypes will be common in males, but nodular sclerosing type is common in females and it is seen in relatively young adults. EBV association is there but not very high. But mixed cellularity type is the one that has the highest EBV association so far, like 70% plus cases will have EBV association, and of course it's going to be common in males compared to that of females. And lymphocyte rich type has a better prognosis compared to all the types of classic Hodgkin lymphoma. If you look at all the histological types of classic Hodgkin lymphoma, the lymphocyte rich type is the one that's going to have a very good prognosis. But the overall best prognosis is NLPHL only. And lymphocyte depleted type is the one that's going to have the worst prognosis. Nodular sclerosing and mixed cellularity will have an intermediate prognosis, average prognosis, but best prognosis is with lymphocyte rich and worst prognosis is with your lymphocyte depleted or lymphocyte poor type only. Usually it will be associated with HIV. And the treatment, of course, is not going to change with the subtype of classic Hodgkin lymphoma. That is the reason why when we talk about clinical practice, these histological subtypes doesn't matter for us, because the treatment for any histological type of classic Hodgkin lymphoma or any type of Hodgkin lymphoma for that matters is going to be the same. It's ABVD plus or minus involved site radiotherapy. That is the treatment that we are going to use. No change. Here is an example of a classic Reed-Steinberg cell. You can clearly notice the characteristic prominent nucleoli with perinuclear clearing, and it typically has a kind of a owl's eye appearance. Bilobe nucleus, prominent nucleoli, perinuclear clearing. So that is typical. So this is a classic Reed-Steinberg cell. Here is an example of a popcorn type cell, a lymphohistiocytic type of cell. So that appears like a kind of a popcorn in the center. So that is characteristic of NLPHL, that is nodular lymphocyte predominant Hodgkin lymphoma. So classic Hodgkin lymphoma on the left, NLPHL on the right. So coming to the staging of Hodgkin lymphoma. So currently we are going to use something called as Cotswolds modification of the original Ann Arbor staging. Initially we had the Ann Arbor staging, but right now there have been plenty of modifications with that of Ann Arbor staging, and currently we follow the Cotswolds modification system. So we have 4 stages, as you all know. Stage 1 in the sense only one lymph node will be involved or only one lymph node group will be involved. Like cervical means cervical, axillary means axillary. The most common lymph node group that is involved in any lymphoma is cervical node. Hodgkin lymphoma, cervical node. So if they ask you the most common lymph node group involved in any lymphoma for that matters, answer is going to be cervical lymph node. So what is stage 2? Stage 2 will be at least 2 nodal groups will be involved, but it will be on the same side of the diaphragm. So either above the diaphragm or below the diaphragm, but when it comes to Hodgkin lymphoma, most of the time it's going to be above the diaphragm. So 2 or more lymph node groups will be involved, but it will be on the same side of the diaphragm. Stage 3 means you're going to involve lymph node groups on either side of the diaphragm, above the diaphragm as well as the below the diaphragm. So infradiaphragmatic nodes are also involved in stage 3. Stage 4 is disseminated disease. It can involve extranodal sites like bone marrow. There is bone marrow infiltration, or if there is liver involvement because of the disease, that is going to come under stage 4, disseminated extranodal involvement. There are some important stage modifiers that we may need to know. One is the presence or absence of B symptoms. So if there is B symptom, then you can add a suffix B to it. So remember, B symptoms and absence of B symptoms are important only for Hodgkin lymphoma. Currently, we are talking only about Hodgkin. We are not talking about non-Hodgkin lymphoma because the staging for non-Hodgkin lymphoma will be even more cumbersome. So I'm not going to talk about that right now. And it's not important for exams as well. So if the patient has B symptoms like fever, weight loss and night sweats, I can add a suffix B to the stage. If the patient doesn't have B symptoms, then I'm going to add a suffix here, that is absence of B symptoms. Currently, this is very controversial. And for non-Hodgkin lymphoma, we don't use the suffix B, A and all because really it doesn't matter when it comes to non-Hodgkin lymphoma. And X stands for bulky disease. So technically here the nodes will be huge, like more than 10 centimeter or spanning more than 1/3 of the intrathoracic diameter. We can call it as bulky disease. But in the most recent updated classification systems, there is no longer the term bulky disease is used. The X term has been completely removed. And again, trust me that for non-Hodgkin lymphoma, the definition of bulky disease will be highly variable. And E stands for extranodal extension. That is ENE. It's not extranodal involvement, it is extranodal extension. Here there will be limited involvement of extralymphatic organ, but it should be contiguous with the nodal site. If it's non-contiguous with the nodal site, that becomes your stage 4 disseminated case. So it should be contiguous with the nodal involvement. For example, if there is a lymph node in an area that is involved, surrounding that area some organ may be involved, and that is external extension. So anything beyond that, it is disseminated stage 4. S stands for splenic involvement. And what do you mean by extranodal disease? You can do the corrections, a small correction over there. What do you mean by extranodal disease? Any involvement apart from the lymph node, spleen, thymus and Valdes ring will be called as extranodal disease. When it comes to Hodgkin lymphoma, spleen involvement is considered to be a nodal disease. I'll repeat. When it comes to Hodgkin lymphoma, splenic involvement is considered to be a nodal disease. So any other sites involved apart from lymph node, spleen, thymus and Valdes ring will be put under extranodal disease only. And as I said already, B symptoms are not at all necessary for staging non-Hodgkin lymphoma. It's only important for Hodgkin lymphoma. So there's no need to categorize with the suffix B or A when it comes to non-Hodgkin lymphoma. Even in Hodgkin lymphoma, it is slightly becoming outdated in the recent past. So here is a diagrammatic depiction of different stages in the Cotswold modification of original Ann Arbor staging. So in stage 1, only one lymph node group or one lymph node will be involved. In stage 2, there will be 2 lymph node groups will be involved, but will be mostly contiguous and will be on one side of the diaphragm. In this case, it's above the diaphragm. In stage 3, the lymph node groups will be involved on either side of the diaphragm, both supra and infradiaphragmatic. In stage 4, there will be disseminated involvement, like for example, patients can have liver involvement, bone marrow involvement, bone involvement. So these are all going to tell you that the disease is disseminated. That is stage 4. Coming to the prognostic factors of Hodgkin lymphoma. For early stage disease, you can make use of certain important prognostic factors like elderly age more than 50, poor prognosis. If ESR is more than 50, poor prognosis, or if the patient is having ESR more than 30 along with B symptoms, then you can portend a poor prognosis. And bulky disease, we have discussed, more than 10 centimeter nodes or more than 1/3 of the intrathoracic diameter. So that's also going to tell you a poor prognosis. If 3+ nodal regions are involved, you can say the prognosis is not going to be that good. But the best is to use something called as IPS scoring, but IPS scoring is more validated for advanced stage disease rather than early stage disease. But nevertheless, you can make use of the IPS scoring, International Prognostic System scoring. But trust me, like IPS scoring is a very, very important area and it can be asked in exams. So what are the parameters? There are totally 7 parameters in IPS scoring. You're going to use albumin, you're going to use hemoglobin, you're going to use age, you're going to use the sex, you're going to use the stage of the disease, you're going to look at the WBCs, and finally what is the number of lymphocytes in the peripheral smear. So these are things that you're going to take care of. If albumin is less than 4 grams per deciliter, that indicates a poor prognosis. If hemoglobin is less than 10.5 grams per deciliter, anemia, poor prognosis. Age more than 45, old age, poor prognosis. Males generally tend to have a bad prognosis compared to that of females. Stage 4 disease, needless to say, bad prognosis. If the patient is having severe leukocytosis, WBC count more than 15,000, poor prognosis. And if the lymphocytes are very, very low, like less than 600 as a part of absolute count or less than 8% in the differential count. These are the poor prognostic factors. So each and everything will get a score of 1. So total score will be 7. So but the parameters in exam can be asked. Very, very important for Hodgkin lymphoma, IPS scoring. albumin, hemoglobin, age, sex, stage of the disease, WBCs, and lymphocytes, either absolute or differential count. So how you are going to treat a classic Hodgkin lymphoma? The cornerstone of treatment of classic Hodgkin lymphoma is going to be ABVD plus or minus involved site radiotherapy. So ABVD plus or minus involved site radiotherapy. So BCOP regime can be used in selected high-risk patients and advanced stage disease. BCOP regime can be used only in selected high-risk patients and advanced stage disease. So what is BCOP regime? ABVD we know already. ABVD stands for adriamycin, that is doxorubicin, then bleomycin, vincristine, and dacarbazine. That is ABVD regime. But what is BCOP regime? Here you are going to use bleomycin, then etoposide. It's a very intensive regime. Patients may not tolerate this. Etoposide, and A stands for adriamycin, that is doxorubicin. Adriamycin, that is doxorubicin. And C stands for cyclophosphamide, and O stands for oncovin, which is nothing but vincristine, and P stands for procarbazine, another P stands for prednisolone. So this is the regime, and how to give and the details of all those cycles is not important for you, maybe important for practitioners, but apart from that it's not important. So BCOP regime, you have like 7 drugs in this group, I told you already, and it can be tried in selected high-risk patients and advanced stage disease. After starting some of these chemotherapy drugs, how to assess the response to therapy? So for that, I'm going to use PET. When it comes to Hodgkin lymphoma, PET is a very, very important modality that is used to assess the response to therapy. And there are some new drugs that are approved for classic Hodgkin lymphoma. What are those new drugs? The most important that can be asked in exam is brentuximab vedotin. This is going to come under an elite class of drugs called as antibody drug conjugate or drug delivering monoclonal antibody. This is something that we have discussed in and out in the leukemia chapter itself. So what is antibody drug conjugate? Here you are going to bind to a target molecule that is present on the cancer cell, and they are going to deliver a toxic drug directly to the cancer cell alone. Thereby you can reduce the systemic toxicity. Here the brentuximab component is going to bind to the CD30 of the classic Hodgkin lymphoma tumor cells and is going to deliver a toxic drug called as vedotin selectively to the cancer cells alone. That's why it's an antibody drug conjugate. Brentuximab vedotin can be used in some cases of classic Hodgkin lymphoma. And because some cases of classic Hodgkin lymphoma tend to overexpress the PD-1 and PD-L1 ligands, we can make use of the immune checkpoint inhibitors like pembrolizumab and nivolumab in certain cases as well. How we are going to treat NLPHL? NLPHL treatment will be very similar to that of non-Hodgkin lymphoma because it's a very indolent neoplasm. You can just treat with radiation therapy, or in rare case scenarios, if the tumor is aggressive, you can use the R-CHOP regime plus radiation therapy. You know what is R-CHOP, right? You can use rituximab in the setting of NLPHL because they're going to express CD20. How can you monitor survivors? Number 1. So patients who have underwent radiation therapy, and most of the times Hodgkin lymphoma is going to occur in the cervical area and in the thoracic area, the mediastinal region. That's why patient would have undergone radiation therapy to the chest and the neck. That's why you have to screen for breast cancer, thyroid cancer, and hypothyroidism. And patients who have received Hodgkin lymphoma chemotherapy are at high risk of developing cardiac disease because they would have received adriamycin. What is adriamycin? Adriamycin is nothing but doxorubicin. Doxorubicin can cause cardiomyopathy. That's why you have to screen for cardiac disease, and they would have received bleomycin. And because of that, they would have resulted in pulmonary fibrosis because bleomycin is an important drug that can cause pulmonary fibrosis. You have to screen for pulmonary toxicity as well. And of course, you have to look for second cancers. And we have used some alkylating agents also like cyclophosphamide. So the future risk of treatment-related MDS and AML is very high, and the cytogenetics of treatment-related MDS and AML we have discussed already. And whenever you get a treatment-related MDS AML, it's going to portend a worst prognosis. So you have to screen for these future cancers as well. And apart from that, if the patient has received cyclophosphamide, you also have to screen for bladder cancer, especially if the patient is old age, more than 40 years of age. And certain regimes, especially those regimes contain alkylating agents, are going to be associated with gonadal toxicity and reduced fertility rates in the future. And as a part of your chronic sequelae, many patients complain of chronic fatigue, anxiety, and depression. And this may be multifactorial, not just because of chemotherapy. But gonadal toxicity is a definite feature of DNA topoisomerase 2 inhibitors and of course your alkylating agents as well. And coming to non-Hodgkin lymphoma. Now we have completed Hodgkin lymphoma. Now it's time that we move on to non-Hodgkin lymphoma. First, let us talk about the basics of non-Hodgkin lymphoma. When it comes to epidemiology, the median age at diagnosis of NHLs will be like more than 60 years. We discussed already, and median age is around 65 years. And patients are going to be predominantly males compared to that of females. There is a slight male preponderance, and 85% of the times it's going to be B cell lymphomas, and only 15% of the times it will be T cell non-Hodgkin lymphomas. If you look at the pie diagram, you can understand that when it comes to B cell non-Hodgkin lymphomas, the DLBCL is the most common. The most common B cell NHL is going to be the DLBCL. If they ask you the most common aggressive B cell NHL is also going to be the DLBCL only. And if they ask you the second most common overall is follicular lymphoma, but if they ask you the most common indolent B cell NHL, if they ask you the most common indolent B cell NHL, it's going to be follicular lymphoma. The most common B cell NHL overall is DLBCL, or most common aggressive B cell NHL is DLBCL. The most common indolent B cell NHL is going to be follicular lymphoma. And what are the associated conditions with that of your non-Hodgkin lymphomas? Number one, immunosuppression. Non-Hodgkin lymphomas are very common in patients who are having HIV, or those who are underwent a recent transplant because of immunosuppression, and it can occur on the setting of connective tissue disorders also, like rheumatoid arthritis, SLE, or Sjogren's syndrome. Usually it will be a DLBCL kind of NHL in these situations. And infections also can trigger the development of NHL, like various viruses, parasites, and bacteria are associated with non-Hodgkin lymphomas, especially B cell non-Hodgkin lymphomas. Like for example, Epstein-Barr virus has been linked with Burkitt's lymphoma and your post-transplant lymphoproliferative disorder. HTLV1 has been linked with the T cell lymphoma called as adult T cell lymphoma leukemia type, and HHV8 has been linked to a type of disorder called as multicentric Castleman disease and primary effusion lymphoma. And certain bacterial infections, like for example, H. pylori has been linked to gastric extranodal marginal zone lymphoma. Extranodal marginal zone lymphoma are famously called as maltomas. So gastric maltomas are associated with H. pylori infection, and small intestinal maltomas are associated with Campylobacter jejuni, and orbital adnexal maltomas are associated with Chlamydia psittaci infection, and Borrelia sometimes can cause cutaneous extranodal marginal zone lymphoma or cutaneous maltomas. There has been a probable link with that of parasites as well. Like for example, some studies say that Plasmodium falciparum has been linked to Burkitt's lymphoma, that too especially the endemic Burkitt's in Africa. So first we have to talk about the most aggressive type of tumor. In fact, this is the most aggressive tumor among all the NHLs, that is Burkitt's lymphoma. Sometimes it can produce leukemic dissemination also, and that will be called as Burkitt's leukemia. And there are three types of Burkitt's lymphoma. One is endemic Burkitt's in Africa. Second is sporadic Burkitt's, very common in United States and Europe. And immunosuppression related Burkitt's, which is common worldwide. So what is the median age for endemic Burkitt's? It's going to affect the children 4 to 7 years of age. When it comes to sporadic Burkitt's, it's going to have a bimodal distribution, 11 years, one peak, and you're going to have another peak at 30 years. So young adults and children are the ones which are going to be predominantly affected in sporadic Burkitt's. When it comes to immunosuppression related Burkitt's, most of them will be slightly older adults. The median age is 44 years, and it can occur at any CD4. That's very important. If you are having a patient with HIV developing Burkitt's, it's a very rare situation. It is not like they have to get HIV related Burkitt's only at a very low CD4. It can occur at any CD4. That's a very important point. When it comes to gender, like the male children are commonly affected compared to the female children when it comes to your endemic Burkitt's. And similar to your endemic Burkitt's, in sporadic Burkitt's also, the males are more commonly affected than females. But when it comes to immunosuppression related Burkitt's, there is no gender difference. Males and females are equally affected. Look at the EBV association. When it comes to endemic Burkitt's, 100% EBV association. Some textbooks will 95%, but it's near 100%. And sporadic Burkitt's, 15 to 20% association. And if it's immunosuppression related Burkitt's, it is again 15 to 20%. What is the usual site that will be involved in the setting of Burkitt's lymphoma? The jaw bones. The jaw bones are the ones that are classically involved in the setting of endemic Burkitt's. And sporadic Burkitt's patients are going to present with abdominal mass, especially right iliac fossa mass. That's the classic presentation, and they can present as an ulcerated right iliac fossa mass. And if it's immunosuppression related Burkitt's, they're going to present with a classic lymphoma. They're going to present with lymphadenopathy, and they're going to present with bone marrow involvement that can occur in approximately 30% of the patients. And with any kind of Burkitt's lymphoma or leukemia, the risk of CNS dissemination is extremely high. That is why it's better to consider central nervous system prophylaxis as well. And what will be the morphology? Remember, whenever you evaluate a patient with suspected lymphoma, you have to go in an orderly manner. Straight away, you cannot look at the immunophenotype and confirm that undergrads do, but at an SS level at least, you have to definitely look at the morphology first. Then you have to go to the immunophenotyping, then look at the cytogenetic abnormalities, then finally make a diagnosis and then start treating accordingly. So what will be the morphology? The cells are going to be monomorphic and they're going to be medium-sized cells, not large, not small. That's very important. Monomorphic, medium-sized cells, and they're going to have a basophilic cytoplasm, but the cytoplasm will be small. It will not be very big. They're going to have a basophilic cytoplasm though with prominent lipid vacuoles. That is one of the key feature of Burkitt lymphoma cells. They're going to have prominent lipid vacuoles. I'll show the image. And this is a tumor that's going to be very, very aggressive. The cells are very active, and that's why the proliferation index, that is Ki67, will be more than 95%. Another proliferation index called as MIB1, that also will be more than 95%. And this is very, very important difference with that of DLBCL. If you have any confusion with DLBCL, you need to know that DLBCL cells will be large cells and the Ki67 will be less than 95%. If it's Burkitt's, Ki67 will be more than 95, extremely aggressive tumor. And you're going to have a characteristic starry sky pattern. I'll show the image as well. And that is because of the presence of the so-called tingible body macrophages in between sheets of tumor cells. And what will be the immunophenotyping? Immunophenotyping will show positive CD10 but negative CD5 and CD23. Along with BCL2 will be negative, and they are also going to test negative for TDT. So CD10 positive, apart from the CD5, CD23, BCL2 and TDT will be negative. Remember, CD10 positivity tells you that the tumor is originating from the germinal center, because CD10 is basically a germinal center marker. So what will be the cytogenetics? Usually translocations will involve the c-MYC gene in chromosome number 8. So c-MYC is located in 8q24, and the c-MYC translocation will be seen in almost all patients of Burkitt's lymphoma or Burkitt's leukemia. So that's why everywhere you will have involvement of 8. Everywhere you will have involvement of that 8th chromosome. So 814, 28 or 822, anything can be there, but 814 is classic and the most common, where the c-MYC is going to fuse with the immunoglobulin heavy chain in the chromosome number 14. And what are the features that exclude the possibility of Burkitt's lymphoma? In case if you have rearrangements in BCL2 or BCL6, it goes towards probably a DLBCL or a double hit or a triple hit lymphoma. So if you have BCL2, BCL6 rearrangements, do not think about a pure Burkitt's. If the Ki67 is less than 95%, unlikely to be Burkitt's. Of course, if they test positive for BCL2 in flow cytometry also, it is unlikely to be Burkitt's, because BCL2 overexpression is very common in setting of follicular lymphoma also. So Burkitt's, even though it's extremely aggressive, it is a curable disease. You need to know the overall survival is more than 70% at 2 years, and the prognosis of Burkitt's lymphoma can be understood with the help of something called as Bilipy score. That is Burkitt's lymphoma International Prognostic Index, where you're going to use some variables like age. If it's more than 40, poor prognostic factor, give 1 point. LDH more than 3 times the upper limit of normal, poor prognostic factor, give 1 point. If the ECOG performance status is 2 and above, give 1 more point. If the patient is having CNS involvement, then you are going to give 1 more point. So totally we have 1, 2, 3, 4 markers. So if the score is 0, then you can call it as low risk. If the score is 1, you can call it as intermediate risk. And if the score is 2 and above, you are going to call it as high risk. And what is the preferred therapy with regards to Burkitt's lymphoma? So the R-CODAX MR-IVAC regime is the one that is preferred therapy. So what is R? Definitely we are going to use rituximab. C stands for cyclophosphamide. O stands for oncovin. That is nothing but vincristine. And DOX stands for doxorubicin. DOX stands for doxorubicin. M stands for high dose methotrexate. High dose methotrexate. Many times we use intrathecal methotrexate as well. And again, in the next cycle, we'll be using R-IVAC. R-IVAC stands for rituximab. I stands for ifosfamide. Rituximab and I stands for ifosfamide. VA stands for etoposide. And C stands for cyclophosphamide again. So we have R-CODAX MR-IVAC regime. So this is the standard regime that we follow for patients with Burkitt's lymphoma. And it's important that you have to consider TLS prophylaxis, that is tumor lysis syndrome prophylaxis, for every single patient. And because the risk of CNS dissemination is very high, we have to opt for CNS prophylaxis as well with the help of intrathecal methotrexate. And here C stands for cytarabine. Okay, not cyclophosphamide. C stands for cytarabine. So you have to strongly consider intrathecal methotrexate plus or minus intrathecal cytarabine, that is Arasi. And here is the classic starry sky appearance. You can notice. So the reason for the starry sky appearance is the presence of this so-called small tingible body macrophages that's going to appear like stars in the sky. So the sky is nothing but sheets of tumor cells. In that, the stars will be the tingible body macrophages. And you can notice the characteristic Burkitt lymphoma cells. They're going to have intensely basophilic cytoplasm, and you can notice the presence of vacuoles. These are vacuoles. These white structures are basically nothing but vacuoles. And if you zoom in and see, you can see things better. You can see the vacuoles very nicely in the cytoplasm, basophilic cytoplasm with vacuoles. Here is a classic example of endemic Burkitt's, which is going to present with the jaw mass. And here is an example of a sporadic Burkitt where the patient is going to present with an ulcerated right iliac fossa mass, and it can be picked up in imaging as well as in endoscopy. And coming to DLBCL, that is diffuse large B-cell lymphoma, the most common B-cell NHL, or we can say most common aggressive B-cell NHL in the world right now. So it contributes to approximately like 1/3 of the NHL cases, and the peak incidence is approximately 6th decade. And what you're going to see in histopathology, you're going to see large cells with loss of follicular architecture of the node. That's what you're going to see in the histopathology. In fact, the loss of follicular architecture of the node is quite characteristic of any lymphoma, not just DLBCL. But the identification of the large cells is going to be the key. Whenever you see a enlarged lymph node with large monomorphic cells, always think about DLBCL as a possibility, especially if the patient is an elderly individual. And 60% of DLBCL is going to present with nodal disease, and 40% is going to present with extranodal disease. And the usual sites of extranodal disease will be the GI tract, especially the stomach, or it can present as a primary CNS lymphoma, or it can present as testicular lymphomas, or it can present as cutaneous lymphomas, but skin lymphomas are quite rare. Bone marrow involvement is going to occur in approximately 1/3 of the patients, and again approximately 1/3 of the patients are going to have B symptoms. DLBCL, like Burkitt's lymphoma, is an aggressive tumor. That is the reason why it is going to be curable in more than 60 to 70% of the cases. More than 2/3 of the cases will be curable, even if they are going to present in advanced stages. And the median survival is going to be in the order of weeks to months in case if we don't treat on time. That's why early diagnosis is important. So first you have to look at the histopathology. You're going to see large cells. That's the most important. There will be large monomorphic cells, fine chromatin, and there will be a definite architectural loss like in any cancer that's involving the lymph node. And the Ki-67 will be less than 95%. Even though it's an aggressive tumor, it's not going to have an extremely high proliferation index like your Burkitt's. The Ki-67 will be less than 95. That's a very important differentiating point. There are two histological types, but it's not important for clinical practice. One is centroblastic and second is immunoblastic type. And currently we are going to look at the immunophenotyping and cytogenetic markers to find out whether it's going to be very aggressive or it's going to respond to therapy or not just the centroblastic versus immunoblastic discussion. So that's why I have not discussed that in detail. In the immunophenotyping, you have to definitely look for CD10 expression, BCL6 expression, and MUM1 expression. That is because you have to differentiate between germinal center B cell type DLBCL and ABC type DLBCL. Generally, ABC type DLBCL or activated B cell type DLBCL tends to have a relatively poor prognosis. And definitely one also has to look for BCL2 and MYC expression, because some DLBCL can have BCL2 and MYC overexpression, and accordingly they will be called as double hit lymphomas or even triple hit lymphomas. And whether it's a true cytogenetic change or it's just excessive expression or not is very important, because if there's a true cytogenetic abnormality, it will be called as a double hit or a triple hit lymphoma. But if it's just overexpressing the BCL2 and MYC, that will be called as double expressor or triple expressor lymphomas. That is different. Remember, increased expression, as I was telling, increased expression is not equivalent to rearrangement. Rearrangement is different. That is gene fusion. That is different. That's called a double hit or a triple hit. Only increased expression without rearrangement means they will be called as double expressor or triple expressor lymphoma. So technically, the double hit and triple hit lymphomas are going to have the worst prognosis, followed by the expressor lymphomas, and followed by the ABC type, and followed by the the germinal center B cell DLBCL. That's going to have a relatively better prognosis. So double hit, triple hits, worse prognosis. To be honest, not just Burkitt's, even DLBCL can have c-MYC overamplification and c-MYC expression. That is, a DLBCL is a diagnosis of exclusion. You cannot just like that make a diagnosis of DLBCL. You have to rule out other things to make a diagnosis of DLBCL. In the cytogenetics, definitely you are going to look for the BCL2, BCL6 and c-MYC rearrangements. As I told you already, there is no single cytogenetic change that's going to be diagnostic. Basically, it's a diagnosis of exclusion based on histopathology and you are excluding other disorders as well. So how to find out whether it is a germinal center B cell type or activated B cell type? We are going to follow something called as Hans algorithm. So first look at CD10. If CD10 is expressed, it's a proper germinal center marker. That's why we can call it as germinal center B cell type DLBCL. If it is negative, next step is to look at BCL6. If BCL6 is negative, then you can say it's a non-GCB, that is usually a ABC type DLBCL. If BCL6 is positive, then you have to look at MUM1. If MUM1 is negative, you can confirm it's a germinal center B cell type DLBCL. If it's positive, MUM1 is positive, MUM1 is basically not a germinal center marker. That's why if MUM1 is positive, then you can say it is an activated B cell type of DLBCL or non-germinal center B cell type of DLBCL. This is the Hans algorithm that can be asked in exams. And coming to the prognosis of DLBCL, we use IPA score for DLBCL separately. The mnemonic for that is APPLES. So A stands for age more than 60, 1 point. P stands for performance status. If it's 2 and above, 1 point. And increased LDH of any level, so we're going to give 1 point. If it's more than upper limit of normal, 1 point. So more than one extranodal site, if it's involved, 1 point. Stage 3-4 disease, you're going to give another 1 point. So you're having total of 5 points, isn't it? So in that 0 to 1 is going to tell you low risk, 2 to 3 is going to tell you intermediate risk, and 4 to 5 is high risk. And there is another scoring system called as CNS IPI, that is Central Nervous System International Prognostic Index. It uses an additional variable, that is kidney and adrenal involvement. If it is there, it's going to increase the risk of CNS disease. That is the idea. And treatment of DLBCL is extremely complex. It depends on what is the background cytogenetics and what they are expressing. So the treatment of double hit, triple hit lymphomas will be different compared to that of the standard GCB and ABC type of DLBCLs. So the standard therapy is R-CHOP. That's what you need to know. Plus or minus, you can opt for something called as involved site radiotherapy. That's the standard of care in the current practice. And in case if the patient is having advanced disease, then you can use a hybrid regime called as R-Pola-CHP instead of your Oncovin, that is vincristine. I'm using polatuzumab. So polatuzumab vedotin is actually an antibody drug conjugate. It's an ADC. So here the polatuzumab is going to bind to the CD79B of the cancer cells, and it's going to deliver a toxic drug to the cancer cells specifically called as vedotin. So that is polatuzumab vedotin. Instead of the Oncovin part, I can substitute that with polatuzumab. That's called R-Pola-CHP. This can be tried in case of advanced disease. That polatuzumab vedotin is approved for use in DLBCL as of now. And because the risk of CNS dissemination is quite high, you can consider CNS prophylaxis, not for all patients like Burkitt's, but if the CNS IPA is more than or equal to 4, especially if the patient is having kidney or adrenal involvement, as I said already. Additionally, if the patient is having testicular or breast involvement, also you can consider CNS prophylaxis, or if the tumor is already involving the epidural space, not as such involve the central nervous system, but has already involved the epidural space, you can consider CNS prophylaxis. And in more aggressive tumors like double hit or probably even triple hit lymphomas, it's better to consider CNS prophylaxis, but not for all patients. That's what you need to know. For Burkitt's, all patients we considered CNS prophylaxis, but for DLBCL, only for selected patients with high risk factors. And what are the newer options that are available apart from the polatuzumab? So we have CD19 CAR-Ts that are specifically approved for Burkitt's, DLBCL. One drug is called as Lisocel, that's called as Lisocabtagene maraleucel, and we have another drug called as Axicabtagene ciloleucel. It is also called as Lisocel. The original name is Lisocabtagene maraleucel, and we have Axicabtagene ciloleucel, that's otherwise called as Axicel. So these are the two drugs that are approved for treatment in DLBCL. These are CD19 CAR-T therapies. We have other anti-CD19 options as well, like we have a antibody drug conjugate. We have antibody drug conjugate called as loncastuximab tesirine. And we also have another anti-CD19 monoclonal antibody. This is not a drug conjugate, this is a pure monoclonal antibody called as tafasitamab. That's called as tafasitamab. So these are the newer anti-CD19 options. And in multiple myeloma also, selinexor is approved. Selinexor is nothing but selective inhibitor of nuclear export, which is basically going to inhibit a protein called as exportin. And this drug is approved in two situations importantly. One is multiple myeloma and second is DLBCL. So we're going to talk about a special type of DLBCL called as PMBL, or primary mediastinal B-cell lymphoma. So it's going to affect the mediastinal lymph nodes predominantly. As the name implies, it's going to involve the mediastinal lymph nodes primarily. So it's a very, very aggressive lymphoma, even aggressive than your standard DLBCL, and it's going to arise from the thymic medullary B cells. It's going to arise from the thymic medullary B cell. The cell of origin are thymic medullary B cells. Unlike your standard DLBCL that's going to affect the older population, this is going to affect the younger population of the 20s and 30s, and predominantly females will be affected compared to that of males, and most of them will have overamplification of the PD-L1 and L2. These are immune checkpoints, right? So they're going to have overamplification of PD-L1, L2, which is classic. And because of the rapid growth in the mediastinal area, they can compress the SVC, resulting in superior vena cava syndrome. They can produce cough, shortness of breath, and even hoarseness of voice. And diagnosis requires surgical biopsy. Because it's a lymphoma, of course, we need a biopsy. And because it's a mediastinal tumor, we need an open surgical biopsy from the mediastinum, or at least we have to do a thoracoscopic biopsy. In case if you think about bone marrow infiltration, you can do a bone marrow aspiration biopsy as well. That is optional. That is generally not required, but if you want, you can do. Optimal treatment is currently unknown, but the preferred therapy is R-epoch. Preferred therapy is R-epoch. So you know what is R-CHOP. R-CHOP can be tried, but R-epoch is better for very aggressive tumors like primary mediastinal B-cell lymphoma or double hit or triple hit lymphomas. It's better to go for R-epoch therapy. So it's like a standard R-CHOP. You know what is R-CHOP, right? Rituximab, cyclophosphamide, hydroxydaunorubicin, that is doxorubicin, oncovin, vincristine, that, and finally prednisolone. In R-epoch, you are going to additionally add etoposide. That's it. The E component is etoposide. Otherwise, it's the same R-CHOP regime only. And how will you differentiate between primary mediastinal B-cell lymphoma, DLBCL, with secondary mediastinal involvement, and classic Hodgkin lymphoma? Remember, primary mediastinal B-cell lymphoma sometimes can give rise to confusions with that of classic Hodgkin lymphoma, because PD-L1, L2 overexpression can be seen in both primary mediastinal B-cell lymphoma and even classic Hodgkin lymphoma. And RS-like cells also can be seen in primary mediastinal B-cell lymphoma, giving rise to a strong confusion between both of these entities. But of course, the DLBCL will not express PD-L1, L2, and the standard DLBCL is not going to have RS-like cells as well. And when it comes to pan B-cell antigens, especially CD19, 20, of course, this is a B-cell NHL, proper B-cell NHL, so both of them will express the pan B-cell antigens, but classic Hodgkin lymphoma is not going to express the pan B-cell antigens like CD19 and especially CD20. And CD15 and 30 expression will be very, very strong in the setting of classic Hodgkin lymphoma, but primary mediastinal B-cell lymphoma usually does not express CD15, but CD30 expression can be there, but it will be only weak. It will not be a strong expression. Whereas your standard DLBCL will not express CD15 and 30 at all. And CD200, otherwise called as MAL expression, is quite common with primary mediastinal B-cell lymphoma. That's actually quite specific for primary mediastinal B-cell lymphoma. And standard DLBCL with secondary mediastinal involvement and in classic Hodgkin lymphoma, you're not going to see CD200 expression at all. Coming to mantle cell lymphoma is one of the worst lymphomas because it's incurable, number one, and it has features of both aggressive and indolent neoplasm. We don't know what category to keep it under. It's neither aggressive nor indolent. So it's actually a worst lymphoma. It's incurable. So it's going to contribute to 3 to 10% of all the non-Hodgkin lymphomas, especially B-cell NHLs. It's going to be quite common in females compared to that of males. And the average age at the time of diagnosis is going to be 60 to 65 years. Like any other standard non-Hodgkin lymphoma, the presentation age will be old. And as I told you, it's going to have worse features of both low and high grade tumor, and it is technically incurable by standard therapy. And the median overall survival with regards to mantle cell lymphoma is hardly 4 to 5 years, but if the patient is young and fit, they can survive up to 8 to 12 years as well. And 90% of them, because it's a kind of a slow growing tumor, 90% of them are going to present with advanced disease like stage 3, stage 4 disease. And most of them tend to have splenomegaly, bone marrow infiltration, and leukemic involvement at the time of presentation. And 50% of the patients, almost half of the patients, tend to have at least more than 2 extranodal sites involved, especially the gastrointestinal tract and the liver. And microscopic disease is extremely common in GIT in more than 90% of the patients. And that is why before starting therapy, prior pan endoscopy is very, very important. And you have to look for this classic polypoid lesions. And if they ask you which of the NHLs can result in polyposis or polypoid lesions, think about mantle cell lymphoma. Mantle cell lymphoma has a very, very variable clinical course depending on the cytogenetics and a lot of other things. It can have an aggressive blastoid kind of a disease, or it can behave very indolent as well. And some patients it will be intermediate, neither aggressive nor indolent. Diagnosis in exam is going to be very, very important. They're going to test positive for CD5. That's very, very important. but they will test negative for CD10, CD23 and CD200. Remember, CLL patients will have positivity for CD23 and CD200 apart from CD5. So in exam, they will be asking you how to differentiate between mantle cell lymphoma and CLL. You have to say that it is CD5 positive but negative for CD23 and CD200. And because this is a tumor that doesn't originate from the germinal center, it originates from the mantle area of the lymph node. It will be CD10 negative. So CD10 is a germinal center marker. It will be negative because this is not a germinal center tumor. It's originating from the mantle zone. What is the hallmark cytogenetic change? It is translocation 11-14, and that is going to fuse the cyclin D1 gene in chromosome 11 with the immunoglobulin heavy chain gene in chromosome 14, resulting in cyclin D1 amplification and cyclin D1 overexpression. That is the hallmark cytogenetic change with regards to mantle cell lymphoma. And mantle cell lymphoma will not only be positive for cyclin D1, it will also be positive for SOX11. So this is going to be there even if cyclin D1 expression is negative. So this is very important for cyclin D1 negative mantle cell lymphomas. If at all they ask you if the mantle cell lymphoma is cyclin D1 negative, how you are going to make a diagnosis using SOX11. SOX11 will be invariably overexpressed in almost all the case of mantle cell lymphoma. So what are the differential diagnoses for cyclin D1 positive malignancies? It's not just mantle cell lymphoma. Cyclin D1 can be overexpressed in certain types of DLBCL. It can be overexpressed in hairy cell leukemia, and it can be overexpressed in myeloma. Even cyclin D1 can be, mutations can be seen in patients with multiple myeloma as well. We'll talk about that in the plasma cell disorder section. And we use a scoring system called as MIPI score, that is Mantle Cell Lymphoma International Prognostic Index. So we're going to use 4 variables technically. So age more than 50 is going to tell you poor prognosis. LDH more than the upper limit of normal, poor prognosis. Performance status more than or equal to 2, poor prognosis. And leukocytosis is also going to carry a poor prognosis. Even though we use 4 variables, this is a point scoring system. This is going to be a point scoring system. So I'm not going to talk about the details of the point scoring system. If you have interest, you can go and look at yourself. Only the variables are important. So you're going to have a point scoring system in that if the points is 0 to 3, you can call it as low risk. If it's 4 to 5, you can call it as intermediate risk. And if it's 6 to 12, you can call it as high risk. So the total score will range from 0 to 12. The score will range from 0 up till 12 in the MIPI score. And how you're going to treat? If it's stage 1, 2, very rarely, if they're present with stage 1, 2, you can just opt for involved site radiotherapy. You can try it out. In case of advanced stage, which is going to be the usual scenario, if they're present in stage 3, 4, you're going to go for combination therapy with BR regime. What is BR regime? You can go for bendamustine and rituximab. This regime can be used for Waldenstrom's macroglobulinemia also. That's called bendamustine rituximab combination, or you can go for the standard R-CHOP regime. In case if the patient is having a relapsed mantle cell lymphoma, you can opt for something called as Bruton's tyrosine kinase inhibitors like ibrutinib or acalabrutinib. So this is all about mantle cell lymphoma. Here is an example of a polypoid lesion in the GI tract because of mantle cell lymphoma. And coming to the next tumor, that is marginal zone lymphoma. So marginal zone lymphoma is basically an indolent neoplasm of the post-germinal center B cells in the marginal zone. So they are not going to originate from the germinal center. That's why they will be CD10 negative. They will not be CD10 positive because CD10 is a germinal center marker. And how they are going to present, the clinical features will completely depend on the involved site. So accordingly, we have 3 types. One is extranodal marginal zone lymphoma, otherwise called as maltoma famously. Second, we have splenic marginal zone lymphoma. Third is nodal marginal zone lymphoma. So extranodal marginal zone lymphomas are usually due to chronic antigenic stimulation. Like for example, H. pylori in the stomach can cause gastric maltoma. Chlamydia psittaci in the orbital region can cause orbital adnexal maltomas. And in patients with Sjogren syndrome, because of persistent immune stimulation, patients can develop salivary gland maltomas. And because of Campylobacter jejuni colonization in the small intestine, it can result in small intestine related maltomas. And because of Borrelia infestation, sometimes patients can develop cutaneous maltomas as well. And apart from these areas, maltomas can occur in the lung, breast as well as in the thyroid, but that's very, very rare. In exam, they will target only the H. pylori related gastric maltomas. That's what they're going to target. And the next type is splenic marginal zone lymphoma, that is SMZL. Here you're going to see characteristic villous lymphocytes in the peripheral smear. That's very important because you're going to confuse this sometimes with hairy cell leukemia, villous lymphocytes in the peripheral smear. And one important thing about splenic marginal zone lymphoma is the fact that it can be associated with hepatitis C virus. This is a very, very important question. HCV can result in splenic marginal zone lymphoma, and 20% of these patients with splenic marginal zone lymphoma can have autoimmune features, additional autoimmune features. And what about nodal marginal zone lymphoma? These tumors are going to show similarities with other marginal zone lymphomas, but they're going to predominantly present with lymphadenopathy. They're not going to present like other tumors that we have discussed, even though they have properties that are shared with other marginal zone lymphomas, but the presentation will be with lymphadenopathy. That's why it's called as nodal marginal zone lymphoma. How you're going to make a diagnosis? Again, like your DLBCL, you don't have any disease-defining immunophenotypic markers. You have to rule out other lymphomas and make a diagnosis of marginal zone lymphoma. But the characteristic immunophenotyping will show negativity for CD5, CD23, cyclin D1 and CD10. Why CD10 negative? Because it's not a germinal center B-cell tumor. And CD5 and 23 will be negative. Remember, mantle cell lymphomas will be CD5 positive, and your CLL will be CD5 and CD23 positive. But here CD5, CD23 both will be negative. Cyclin D1 expression also will not be there, and CD10 also will be negative. And in some cases of extranodal marginal zone lymphoma, you can see the characteristic cytogenetic abnormality, that is translocation 11-18, and this is especially seen in H. pylori negative cases. In H. pylori positive cases, you may not be seeing the characteristic T11-18 translocation. So in H. pylori negative extranodal marginal zone lymphomas, T11-18 can be seen. And if they ask you the most common cytogenetic change, answer is trisomy 3. This is the most common cytogenetic change seen in almost 2/3 of the patients. Other cytogenetic abnormalities like T14-18, T114 and T314 can occur, but trust me, T14-18 also will be seen in follicular lymphoma, but there you are seeing different rearrangement. Of course, there the rearrangement will involve the immunoglobulin heavy chain, but in the 18th chromosome in follicular lymphoma, there will be something called BCL2 that will fuse with immunoglobulin heavy chain, resulting in BCL2 overexpression. That is for follicular lymphoma. But here we are going to fuse something called as MALT1. So there will be MALT1 fusion. MALT1 from chromosome 18 will fuse with the immunoglobulin heavy chain. So this 14-18 is different. This is MALT fusion, not BCL2 fusion like follicular lymphoma. Apart from that, so it can be like T114 or T314 translocations as well. So first of all, how to treat? You have to treat infections. So majority of the extranodal marginal zone lymphomas will be due to underlying infections. So just treating those infections itself will remove the antigenic stimulation so that your maltomas can be cured. So if it's a H. pylori related gastric maltoma, the treatment of choice, if they ask you, is H. pylori eradication. In case if H. pylori eradication fails to cure the maltoma, or if patient is H. pylori negative and having a gastric maltoma, then you can opt for either involved site radiotherapy or even chemotherapy if the disease is advanced. You can even go for R-CHOP therapy. It all depends, and those details are not at all required. But in exam, they will ask you H. pylori related gastric maltoma, treatment of choice is H. pylori eradication. So imagine a cancer can be cured without any chemotherapy, just with H. pylori eradication. That's the beauty of this cancer. So you can see the characteristic villous lymphocytes. This is characteristic of splenic marginal zone lymphoma. And you can look at the characteristic mucosal nodularity with friability, edema and erythema in the setting of gastric extranodal marginal zone lymphoma. You can see how edematous, friable and erythematous your gastric mucosa. That is suggestive of a gastric extranodal marginal zone lymphoma. And coming to follicular lymphoma, it's the most common indolent neoplasm. Most common indolent neoplasm in the world, and the second most common B-cell NHL in the world right now. So it is the commonest low-grade lymphoma, and the median age is again like any other classic NHL. It's going to be in the old age, like 60 to 65 years, and 85% plus follicular lymphoma patients are going to present with advanced stage at the time of presentation, like stage 3-4, because it's an indolent tumor. Many patients will be asymptomatic, and it will be disseminated at the time of presentation. Follicular lymphoma is technically a germinal center tumor, so CD10 expression will be there, and it's a typical centrocytic tumor, but the presence of centroblast will change the grade. More the centroblast, higher the grade of the tumor. Lesser the centroblast, lesser is the grade of the tumor. So, but traditionally speaking, it's a centrocytic tumor. But in the current practice, we don't use those terms like centrocytic tumor. It's follicular lymphoma. That's it. Clinically, it's going to present as a painless peripheral lymphadenopathy, and most of the textbooks use the term called as waxing and waning type of lymphadenopathy. So painless peripheral lymphadenopathy, especially involving cervical or axillary nodes, characteristic. And these tumors can transform into more aggressive forms, especially DLBCL. So the risk of transformation is approximately 3% per year. And what are the clues for like transformation into an aggressive form of lymphoma like DLBCL, rapidly enlarging nodes. That doesn't occur in a classic follicular lymphoma. If it is there, you can think about transformation to more aggressive types. Increased LDH. Suddenly LDH starts getting elevated. And if the patient starts developing B symptoms, especially like fever, weight loss, night sweats. And coming to the diagnosis. So first you have to look at the morphology. So they're going to have a characteristic follicular growth. So you're going to have small cells with mixture of both centrocytes and centroblasts. That's why the term centrocytic tumor has been removed in the recent past. And the proportion of centroblasts is the one that's going to determine the tumor grade. This is something that I've told already. So what will be the immunophenotyping and immunohistochemical markers? CD10 expression will be there because it's a germinal center tumor. And more importantly, there will be BCL2 overexpression. BCL2 positivity is a must for the diagnosis of follicular lymphoma. And BCL6 can also be positive, but that's not important. The BCL2 is the one that's going to be the most important. That defines follicular lymphoma in most situations. But they will test negative for CD5, CD23, CD43 as well as cyclin D1. That is helpful for ruling out other types of lymphomas. What is the typical cytogenetic change? It is T1418. But here it will involve the BCL2 gene in chromosome 18. So the BCL2 gene in chromosome 18 will fuse with immunoglobulin heavy chain in chromosome 14. And that will be seen in almost all the cases, 100% of the cases. That's why this is the hallmark and the signature cytogenetic change that is associated with follicular lymphoma. Very commonly asked in exam. And prognosis can be assessed with the help of something called as Philippi score. So number 1, old age more than 60. Number 2, increased LDH more than upper limit of normal. Third, anemia, hemoglobin less than 12. And stage 3, stage 4 disease and more than 5 nodal areas if it's involved or not. So you have 5 points for this. If it's 0 to 1 low risk, 2 intermediate risk and 3 to 5, you can call it as high risk. So the grade of the tumor is the one that's going to tell you the treatment, honestly speaking, rather than the Philippi score itself. So if the tumor is of low grade, then you can just go for involved site radiotherapy if the tumor is in stage 1. If it's stage 2 to 4, then you can go for standard chemo options. What are the chemo options? We have BR regime. What is BR? This is bendamustine with rituximab. Or you can use only R, that is rituximab, or R square. What is R square? You can use rituximab along with lenalidomide. Lenalidomide also is called by suffix R. So you can use rituximab along with lenalidomide. That's called R square. So in low grade tumors, even if it's stage 2 to 4, therapies will be BR regime, only rituximab, or R square, which is nothing but rituximab with lenalidomide. If it's a high grade tumor, you're going to treat just like a DLBCL. That is going to be with R-CHOP regime. That's it. You know what is R-CHOP. I'm not going to tell again. Here is the characteristic histopathological image that can be asked in exam. They will ask you how to differentiate between reactive nodular hyperplasia and follicular lymphoma. On the left side, you have reactive nodular hyperplasia. There are increased number of follicles, all right, but they are reactive follicles and they're nicely arranged in the periphery, in the cortex. The lymph node architecture is not changed. It's not damaged. But here, there is a total loss of lymph node architecture and the entire lymph node through and through is replaced by these small follicles. So many times follicular lymphoma is something that can be diagnosed just by looking at the slide macroscopically. No need to even look at the microscope. It's so obvious. And if the follicular lymphoma cells enter the blood via leukemic dissemination, you're going to see the characteristic cleaved cells in the peripheral nucleus. They will have cleaved nucleus. These cells with cleaved nucleus are also referred to as something called as bud cells. They're also called as bud cells. Beautiful name, bud cells. Cleaved nucleus. And coming to the next indolent neoplasm, that is hairy cell leukemia. Hairy cell leukemia is a tumor that is originating from post-germinal center memory B cell. Post-germinal center memory B cell. And it's quite common in males compared to females at a ratio of 4 to 5:1. You can make a correction. It's going to be more common in males compared to the females. And the median age at the time of presentation is 58 years, old age, just like any other NHL. And what will be the clinical features? Massive splenomegaly. That's the most important point. They're going to just present with massive splenomegaly, plus or minus they can have cytopenias as well because of bone marrow infiltration. They will have disease in the bone marrow as well because it's a leukemia, hairy cell leukemia. So because of cytopenias like anemia, patients can come with fatigue or they can come with infections because of neutropenia or they can present with bleeding because of thrombocytopenia. Usually these patients don't have lymphadenopathy and don't have B symptoms. Very, very important. Very rarely they have B symptoms. And monocytopenia is almost always in straight line from hairy cell. Monocytopenia, almost always seen. How are you going to make a diagnosis of hairy cell leukemia? Morphologically, you will see hairy cells in the peripheral smear, but if you do bone marrow aspiration or biopsy, you are going to see the characteristic fried egg cells. Aspiration often is going to yield a dry tap. It's one of the important cause of dry tap. And if you do immunophenotyping or immunohistochemistry, you will see that CD11C will be positive, CD103 will be positive, and CD123 will be positive. Along with that, CD25 will be positive. This is called as hairy cell panel. CD11C, 25, 103, 123. This will be positive. Very important for exams. In that, at least remember 103. And annexin A1 is considered to be the most specific marker for hairy cell leukemia. It will be positive. And apart from that, CD200 can be positive, DBA44 can be positive, and even SOX11 can be positive. But think about the hairy cell panel in exam. That 11C, 25, 103, 123. Very, very important, along with annexin A1, specific for hairy cell leukemia. And most of the patients, virtually like 95 to 100% of the patients, will be having BRAF V600E mutations. So there are very specific cancers that tend to have the BRAF mutations. Hairy cell leukemia is one among them. BRAF V600E mutation, the signature BRAF mutation. And it's seen in virtually almost all the case of your classic hairy cell leukemia. And now we're going to treat, again a famous exam question, the treatment of choice is going to be cladribine. And there is a newer drug called as moxetumomab pasudotox. It is an antibody drug conjugate as usual. You're going to target the CD22 of the leukemic cells, and you're going to deliver a toxin called as Pseudomonas exotoxin, that is pasudotox, directly on the cancer cells alone. That's called as moxetumomab pasudotox. It's been approved for relapsed cases of hairy cell leukemia. In case if the patient is having BRAF positivity, BRAF V600E positive, then you can use BRAF inhibitors like vemurafenib also. It's also approved for relapsed disease. So two drugs, don't forget, for hairy cell leukemia. One is vemurafenib because it's going to be BRAF positive, and second is moxetumomab pasudotox. It is an antibody drug conjugate. The monoclonal antibody is targeted against the CD22, and there will be a Pseudomonas exotoxin that will be the toxin over there that's going to be delivered to the hairy cell leukemia cells. Here is the characteristic TRAP positivity, that is tartrate resistant acid phosphatase positivity, that is seen in patients with hairy cell leukemia. And here are the characteristic hairy cells that are seen in classic hairy cell leukemia. And these are the characteristic fried egg cells, because there will be perinuclear clearing in the cytoplasm, and that will look like fried eggs in the bone marrow. So these are the characteristic fried egg cells that are seen in the setting of hairy cell leukemia. So that's a bone marrow aspirate. Seeing hairy cells doesn't always mean it's hairy cell leukemia. It can be hairy cell leukemia classic form or hairy cell leukemia variant form, or it could be splenic marginal zone lymphoma as well. We have to differentiate. First, let us look at the nuclear characteristics. It will be typically kidney shaped in the setting of hairy cell leukemia. It will be round or round to oval shaped in the setting of hairy cell leukemia variant and your splenic marginal zone lymphoma. Nucleolus will be prominent in the setting of variant hairy cell leukemia, but it will not be prominent in the setting of your classic hairy cell leukemia and splenic marginal zone lymphoma. Cytoplasm will be abundant in the setting of hairy cell leukemia and its variant, but it will be very small and inconspicuous in the setting of splenic marginal zone lymphoma. And these so-called hairy-like cells in splenic marginal zone lymphoma will be called as villous lymphocytes. We have discussed that already. Spleen involvement also can tell you the difference. If you look at the splenic biopsy, the red pulp involvement is characteristic of hairy cell leukemia and its variant, whereas your marginal zone involvement will be characteristic of splenic marginal zone lymphoma, as the name implies. If you look at the bone marrow infiltration, you have a diffuse interstitial pattern with that of your hairy cell leukemia and variant form of hairy cell leukemia, but you're going to have a nodular interstitial pattern in the setting of your splenic marginal zone lymphoma. So that nodularity is quite characteristic. We have discussed that already in the marginal zone lymphoma slide. And CD11C expression can be seen in both hairy cell leukemia and its variant. CD25 expression, though, is common in hairy cell leukemia, not in hairy cell leukemia variant. CD103 expression variable in the setting of variant form of hairy cell leukemia, but it will be definitely seen in the setting of classic hairy cell leukemia. CD123 expression is again classic of your classic hairy cell leukemia. It will not be seen in variant forms. TRAP positivity again in classic forms, not in variant forms. Annexin A1 very specific for hairy cell leukemia, so it's going to be seen in classic forms, not in variant forms. BRAF mutations again going to be seen in classic forms, not in variant forms, but variant forms can show something called as MAP2K1 mutations, approximately half of the cases. So CD11C expression can be seen in both, and CD103 can be variable, but apart from that, most of the features are going to go towards your classic hairy cell leukemia, and will be negative in the setting of variant hairy cell leukemia, except for the mutation MAP2K1 that is seen usually in variant form of hairy cell leukemia. Whatever things that we have seen, CD11C, CD25, 103, 123, annexin A1, BRAF mutations, MAP2K mutations, all of them will be negative in the setting of splenic marginal zone lymphoma. Look at these images, you can understand this is a classic hairy cell leukemia. You can see the characteristic kidney-shaped nucleus with villi distributed throughout the circumference of the cell. Everywhere the villi is distributed. This is a typical classic hairy cell leukemia. On the other hand, if you look at the variant hairy cell leukemia, this is the variant hairy cell leukemia. You can also see the hairy projections here, but the most important point is the prominent nucleolus that you can see. Prominent nucleolus. Along with that, you can also notice that these patients are having more of a roundish nucleus. Roundish nucleus, not the characteristic kidney-shaped nucleus. And if you look at splenic marginal zone lymphoma, these are villous lymphocytes in the peripheral smear, and you can see polar villi. The projections will be located only in some places, especially in the place where cytoplasm is abundant. Only in those areas the villous projections will be there. That's why these are called as villous lymphocytes. They will have polar villi, only in one pole. Villous lymphocytes. You can see how small the cytoplasm is compared to the classic forms of hairy cell leukemia and variant form of hairy cell leukemia. And the nucleus is also more oval in shape, more roundish to oval in shape, not like it's kidney shaped. So coming to the next important topic, that is CLL and SL, chronic lymphocytic leukemia, small lymphocytic lymphoma. It's a very rare tumor. It's not very common, and it's a tumor of very old age, like 70s and 80s. Most patients will be in the 70s and 80s. Median age is approximately 70 years, and it's more common in Caucasians compared to Asians and Indians, and it's surprisingly more common in males compared to that of females. And first we have to have a look at the terms. Chronic lymphocytic leukemia, SLL means small lymphocytic lymphoma, and MBL stands for monoclonal B-cell lymphocytosis. MBL stands for monoclonal B-cell lymphocytosis. So the least severe form is the MBL, monoclonal B-cell lymphocytosis, which can be a precursor for the development of SLL or CLL. So if you talk about monoclonal B-cell lymphocytosis, there will be clonal B cells in circulation. These are neoplastic cells only, but the number will be less than 5,000. And patients will not have lymphadenopathy or splenomegaly. No lymphadenopathy, splenomegaly, and they're going to have less than 5,000 clonal B cells in the circulation. So with the same number, if the patient is having lymphadenopathy plus or minus splenomegaly, that becomes a SLL, small lymphocytic leukemia. If there is leukemic dissemination, if you have more than 5,000 clonal malignant B cells in the circulation for persisting for more than 3 months, that is going to make a diagnosis of CLL, that is chronic lymphocytic leukemia. Here, whether lymphadenopathy is there or not, it doesn't really matter. Whether splenomegaly is there or not doesn't matter here in CLL. CLL means it's leukemic dissemination, more than 5,000 malignant clonal B cells in the circulation persisting for more than 3 months, that is CLL, irrespective of lymphadenopathy and splenomegaly. So now we can understand the three terms, that is CLL, chronic lymphocytic leukemia, small lymphocytic lymphoma, and monoclonal B cell lymphocytosis. So how we are going to arrive at your diagnosis? Look at the peripheral smear. You have to look at the T cell absolute lymphocyte count. It should be more than 5,000 to make a diagnosis of CLL. And most often than not, you're going to see something called as smudge cells. These are fragile malignant B cells that get smeared off while preparing the slide, and those are called as smudge cells, very characteristic of CLL. Plus or minus, you can have spherocytes also in case of autoimmune hemolytic anemia. Autoimmune hemolytic anemia and ITP is very common in the setting of CLL, especially autoimmune hemolytic anemia. I have to rule out that. And if you have autoimmune hemolytic anemia, it will be of warm type generally, and seeing spherocytes is not uncommon. And if you look at the immunophenotyping, they will express CD20, even though it's a dim expression. If you have a good expression of CD20, you can use rituximab also, we'll talk about that. But most importantly, CD5 and CD23 will be positive and CD200 will be positive. I told the importance already in the previous slides when I was talking about other types of lymphomas. Because it's not a tumor of germinal center, CD10 will be negative. Characteristically, CD10 will be negative. But in exam, most of the time, CD5 positivity, 23 positivity is a big giveaway. It's going to tell you that the CLL only. And CD22 will be negative. It will be usually positive in the setting of hairy cell leukemia. And CD79AB also is going to be characteristically negative. And CD11C and 103 will be negative, again ruling out it is not hairy cell leukemia. And cyclin D1 will be negative, suggesting that it is unlikely to be mantle cell lymphoma. And to confirm the clonality of these B cells, you have to just look for the kappa and lambda light chain restriction in the surface immunoglobulin. If it is restricted, then it confirms clonality. You have to just look for the kappa lambda light chain restriction in the surface immunoglobulin of the B cells. Clinically, most of the patients are going to be asymptomatic. Many times it will be diagnosed incidentally through a master health checkup. Most of them will be asymptomatic, but some patients can become symptomatic, maybe courtesy to the cytopenias because of high-grade tumors. They can present with anemia and fatigue, they can present with neutropenia and infections, or they can present with thrombocytopenia and bleeding. And they can have recurrent infection not just because of neutropenia, they can present with recurrent infections because of hypogammaglobulinemia. These are abnormal malignant B cells, right? They're not going to produce good amount of immunoglobulins. So there will be hypogammaglobulinemia, and that is the main reason for infections in these individuals, and that's one of the important reasons for death in these patients also. And approximately 5% of the patients you will be seeing monoclonal gammopathy, and there is something called as Richter's transformation. That is transformation to a higher grade tumor like DLBCL. The usual transformation will be towards DLBCL, that is diffuse large B cell lymphoma, and it's going to occur at a rate of approximately 5 to 10% per year. So Richter's transformation is malignant transformation, or we can say transformation to more aggressive tumors, and that is going to occur at a rate of 5 to 10% per year. Very important question for exams. Here is an example of a characteristic smudge cell in the peripheral space. There is another smudge cell. So these are the malignant B cells that are just smeared off because they are very, very fragile. While preparing the slide, they will be just torn apart. So these are the malignant B cells though. So what are the markers of unfavorable prognosis and what are the markers of favorable prognosis? P53 deletion involving 17p is considered to be the worst prognostic marker. If there is ATM gene deletion, which is going to occur because of the 11q deletion, is also going to tell an unfavorable prognosis. So these patients are going to present with very high grades of lymphadenopathy. And look at the immunoglobulin heavy chain region, especially the variable region of immunoglobulin heavy chain. If it is unmutated, otherwise called as wild type, that's going to carry a poor prognosis. If it's mutated, better prognosis. CD38 positivity in flow cytometry, poor prognosis. ZAP70 positivity, again poor prognosis. So what about favorable prognostic markers? When it comes to cytogenetics, the retinoblastoma deletion, 13q deletion is considered to be favorable, and it's the most common cytogenic change that is associated with chronic lymphocytic leukemia. If it's 12q gain, there's a 12q gain or trisomy 12, is associated with a neutral prognosis, not favorable and not unfavorable either. If the immunoglobulin heavy chain region, variable region of immunoglobulin heavy chain is mutated, then you can say it's a favorable prognostic marker. CD38 negativity and ZAP70 negativity also tells you that the prognosis is going to be favorable. So these are the prognostic markers very commonly asked in exams. And coming to the staging of CLL, SLL, we have two types of staging. One is called as Rai staging, second is called as Binet staging. So first let us talk about Rai staging. We have 4 stages, 0, 1, 2, 3, 4. In stage 0, there will be only lymphocytosis. In stage 1, you will have additional lymphadenopathy, so I can put plus lymphadenopathy. In stage 2, apart from lymphocytosis and lymphadenopathy, there will be additional splenomegaly. In stage 4, if you have anemia especially, remember this should not be an autoimmune hemolytic anemia. If there is anemia, probably because of extensive disease in the bone marrow, that is going to come under stage 3. If the patient is having thrombocytopenia, again because of bone marrow suppression, not because of immune thrombocytopenic purpura, we are going to put under stage 4. So this is Rai staging. What about Binet staging? It is usually for SLL. Rai staging is predominantly for CLL patients. Binet staging is predominantly for SLL patients. So you have Binet A, B and C. If you have less than 3 node involvement, then you are going to call it as Binet stage A. More than 3 node areas if they are involved, that's called as Binet stage B. Whatever may be the nodal involvement, if the patient is having anemia or thrombocytopenia but not immune related, because if it's because of bone marrow suppression, you're going to call it as Binet stage C. So 2 types of staging, Rai staging and Binet staging. And what are the indications for treatment? Remember, most of the indolent neoplasms are not curable. Likewise, CLL is also not curable. It is incurable. So there is no evidence to say that early treatment is going to improve the overall survival. So in selected patients only, you are going to initiate treatment. In most of the patients, you can just wait and watch. So what are the indications for therapy? Number 1, if you have cytopenias due to progressive CLL, typically Rai 3-4, Binet stage C, depending on whether it's CLL or SLL, you can start treatment. That's the usual indication to start therapy. So second, autoimmune hemolytic anemia or ITP, that is refractory to treatment. So remember, whenever there is autoimmune hemolytic anemia or ITP, the first line treatment is corticosteroids. If that is not responding, then you can start with chemotherapy. if the patient is having a lymphocyte doubling time of less than 6 months, lymphocyte doubles, observed lymphocyte count doubles within 6 months, or if it increases by more than 50% from the baseline value within 2 months, these are all indications for treatment. And if the patient is having B symptoms like fatigue, fever for more than 2 weeks, night sweats, weight loss, indication to treat. If the patient is having massive concerning splenomegaly, like more than 6 cm below the left costal margin, indication to treat. Or the patient is having massive lymph nodes like more than 10 cm in size, you can start treating this. These are the usual indications for treatment. Most important usual indication will be cytopenias. That's the reason why we initiate treatment. And there are two treatment options that can be tried. One is BTK inhibitors, the usual treatment, the current treatment of choice, first line treatment. We can use either ibrutinib or acalabrutinib. Most of my patients I treat with ibrutinib. Acalabrutinib is difficult to get in India, but if you can use acalabrutinib also. Bruton's tyrosine kinase inhibitors are the first line therapy. Versus you can use BCL2 inhibitors also. That's called as venetoclax. Because the CD20 expression will be dim in most patients, you can consider anti-CD20 like rituximab, and that depends on how much they are expressing. If they don't express that much, don't try. If they express nicely, then you can go for rituximab as well. But commonly the therapy is going to revolve around ibrutinib versus venetoclax. So now let us have a overview of whatever we have learned so far, because so many things we have learned. So let us try to put into a form of a table. Let us try and consolidate. So first let me talk about the B cell NHLs. First, Burkitt's lymphoma. You know, it's going to be medium-sized cells, starry sky pattern, Ki-67 more than 95%. It's CD10 positivity because it's a germinal center tumor. And c-Myc amplification is 100% seen in almost all the cases. The T814 is the most common. There are others also like T28 and T822. Anyway, it will have 8 in it because you have to have c-Myc overexpression, and c-Myc is seen in chromosome number 8. That's why the involvement of 8 is very characteristic, but the most common is going to be T814. And it's the most aggressive B cell neoplasm ever known. It's going to present as a jaw mass or a GI mass depending on whether it's an endemic or sporadic Burkitt, and the treatment of choice is going to be R-CODAX, MR-IVAC regime. And what about DLBCL? That is diffuse large B cell lymphoma. It's a diagnosis of exclusion. There is no typical cytogenetic change or mutation to say that it's going to be DLBCL. You have to look at the histology. You're going to see large cells, Ki-67 less than 95%, and some patients who is having germinal center type DLBCL can have CD10 positivity or BCL6 positivity as well. So it's basically a diagnosis of exclusion, and there could be plenty of like cytogenetic abnormalities and expressions like BCL2, MYC, MLL2, CRBP. Can see anything in DLBCL. So you cannot confirm based on any particular cytogenetic marker, and it's a very aggressive neoplasm. You know that it can occur anywhere. It can be nodal or it can be extranodal. If it's extranodal, as I've told already, G18 involvement is quite common. Standard therapy is R-CHOP, but newer therapies are there like EPOCAR. So it depends on whether it's a double hit or triple hit. You have to be very careful in that regards when it comes to practice. Next is mantle cell lymphoma. You don't know whether it's indolent or aggressive. It stands somewhere in between. The other two we discussed are aggressive. This is somewhere in between. You're going to see small to medium cells, CD5 positive but CD23 negative. The characteristic signature cytogenetic change is going to be T1114. That's going to over-amplify cyclin D1. And they're not only going to be positive for cyclin D1, they're going to be positive for SOX11 as well, which is actually quite characteristic of mantle cell lymphoma. In fact, this is the most common seen in almost all the cases of mantle cell lymphoma. We know that GI involvement with mantle cell lymphoma is very, very common. Even splenomegaly and bone marrow infiltration is quite common, and most of them are going to present with stage 3-4 disease. And in exam, if they mention polyposis or polypoid appearance of a tumor, which NHL is going to produce polyposis and polypoid appearance, it is mantle cell lymphoma. Multiple options are there for treatment, but you can try something called as R-CHOP regime if the tumor is aggressive. Otherwise, you can treat it more conservatively also. We know about marginal zone lymphoma. We have 3 types: nodal marginal zone lymphoma, extranodal marginal zone lymphoma, and splenic marginal zone lymphoma. And we know that marginal zone lymphoma doesn't have any specific immunophenotyping. You have to rule out other lymphomas to make a diagnosis of marginal zone lymphoma. Even though T1118 is characteristic in certain gastric maltomas, it will not be seen in H. pylori positive cases. And T1418 can be seen. You should not confuse that with follicular lymphoma because the translocation involved is not BCL2 with immunoglobulin heavy chain gene. It's actually maltone fusing with immunoglobulin heavy chain gene. And splenic marginal zone lymphoma can have hairy cells in the peripheral smear, and they will typically have polar villi, otherwise called as villous lymphocytes. We discussed that already. Presentation of marginal zone lymphomas will depend on the site involved, and you're going to treat only if symptomatic because these are basically indolent neoplasms. And we know some cases of gastric maltomas will be due to H. pylori, and you can treat these tumors just with H. pylori eradication. In case if the treatment is failed or if it's not due to H. pylori, then you can use involved site radiotherapy as the first line option. If it's an aggressive tumor, you can go for R-CHOP also. That depends. Coming to follicular lymphoma, we have discussed already. It's the most common indolent neoplasm in the world right now, and it is rarely aggressive, but they can go for aggressive transformation. That's called as Richter's transformation. The transformation rate is approximately 3 to 10% per year, and you're going to see the characteristic follicles in the lymph nodes. Macroscopically itself, you can make a diagnosis. Because it's a germinal center tumor, CD10 will be positive. Typically a centrocytic tumor, but centroblasts are the ones that are going to tell you the grade of the tumor, and most of the patients will be having BCL2 overexpression 100%. T1418 is the signature translocation that's going to overexpress the BCL2, 100% seen in almost all the cases. T1418 translocation, signature cytogenetic change, and it's going to present as a peripheral, painless, asymptomatic lymphadenopathy with waxing waning type we discussed already, and treatment will be with BR or only rituximab or R square we discussed already, or if it's very aggressive, you can even go for R-CHOP. So treatment is highly variable depending on the grade of the tumor. And what about hairy cell leukemia? You're going to see hairy cells in the peripheral smear that are going to be TRAP positive, and most of the classic forms will have that characteristic BRAF V600E mutation, and CD103 and 123 will be positive. Along with that, annexin A1 will be positive. This is very, very specific for hairy cell leukemia. And patients are going to typically present with a massive splenomegaly plus or minus cytopenias, but they don't really have B symptoms and lymphadenopathy. Treatment of choice is cladribine, a purine analog. Coming to CLL and SLL, you're going to see small fragile cells which are basically going to be smeared off while preparing the slide, and that's called as smudge cells in the peripheral smear. And CD523 positivity virtually clinches the diagnosis of CLL or SLL in exams, and of course there will be CD200 positive as well, even though this is not very specific. And patients will be asymptomatic in most situations. Rarely they can present with symptoms of cytopenia, lymphadenopathy, or even splenomegaly. If it is the case, then you can start treatment with what? BTK inhibitors. That's the first line treatment like ibrutinib or acalabrutinib, or you can use BCL2 inhibitor like venetoclax, which is something that we have discussed already. What about the T cell NHLs? There are 4 T cell NHLs that are very important. These are diverse group of disorders, not easy to comprehend. So many are there, but 4 can be asked in exams: mycosis fungoides, Sézary syndrome, adult T cell lymphoma leukemia, and anaplastic large cell lymphoma. 4 can be asked. So when it comes to mycosis fungoides, you need to know this is the most common cutaneous T cell lymphoma. This is the most common cutaneous T cell lymphoma, and you're going to see something called as epidermotrophic lymphoid infiltrates. These are nothing but CD4 cells technically, and you're going to see something called hallowed lymphocytes and Poirier microabscesses. And the site of involvement will be generally the skin plus or minus the local lymph nodes, and they're going to have a distinct evolution. Initially the patch stage, then the scale stage, then plaque stage, then finally they can develop something called as erythroderma as well. So what is Sézary syndrome? It's the same mycosis fungoides only, but it's a leukemic form of mycosis fungoides. If the mycosis fungoides is very aggressive, these cells, cancer cells, can enter the bloodstream from the skin, and if you see those cells in the blood in the peripheral smear, it's called a Sézary syndrome. It's a very aggressive form of mycosis fungoides. That's it. And you're going to see the circulating tumor cells with the characteristic cerebriform nuclei. So characteristic cerebriform nuclei, I'll show the image in a while. And most of these patients with Sézary syndrome will present with erythroderma straight away, and they will definitely have lymphadenopathy, and that will be disseminated lymphadenopathy. And treatment can be just topical if it's a mild form, or if it's a Sézary syndrome, you have to go for systemic treatment, and we have multiple treatment options like that is beyond the scope of the current discussion. And what about ATLL, that is adult T cell lymphoma leukemia? So it is going to be HTLV1 related, and you're going to characteristically see the clover leaf shaped cells in the biopsy. I'll show the image in a while. And most of the cases will be indolent, where they're going to present only with skin lesions, but some of these tumors can be aggressive, resulting in leukemia as well. And the treatment will be highly variable. You can use hyper-CVAD regime, which is nothing but hyperfractionated cyclophosphamide with vincristine, adriamycin, that is doxorubicin, and dexamethasone. That's called as hyper-CVAD regime. Just like your B-cell NHLs, you can treat, or you can treat with CHOP regime. Remember, rituximab cannot be used because anyway they're not going to express CD20 because this is a T-cell neoplasm. So not R-CHOP, just CHOP. And mogamulizumab is a novel drug that can be used for treating ATLL patients because these cells tend to express something called CCR4. And they're going to express CCR4, and the monoclonal antibody against the chemokine receptor CCR4 is called as mogamulizumab, that can be used in ATLL. So that can be asked in exams. And the final T-cell tumor I'm going to talk about is ALCL, that is anaplastic large cell lymphoma. And the most important thing that you have to know for exams is ALK positivity. And most of them will be CD30 positive. And the characteristic signature cytogenetic change will be translocation 2,5, where you're going to fuse the ALK gene with NPM. That will be ALK NPM fusion, and that's very, very characteristic of ALCL. And interestingly, ALCL risk is going to be high in patients who are having silicone implants, especially in females with silicone breast implants. The risk of anaplastic large cell lymphoma is high. And patients can present with lymphadenopathy and hepatosplenomegaly, and the treatment will be EPOCH usually. I cannot use rituximab again because it's a T-cell neoplasm. It's not R-EPOCH, it's just EPOCH. And you can use brentuximab, interestingly, because these tumors also have expression of CD30. As I told you, like your classic Hodgkin disease, they can also express CD30. That's the reason I can use brentuximab vedotin. Here is a classic example of a patient who is presenting with anaplastic large cell lymphoma. If they use the term horseshoe-shaped nucleus, that is typical of anaplastic large cell lymphoma. These are basically Sézary cells. You can see the characteristic brain-like folds in the nucleus. They're also called as cerebriform nucleus. Brain-like folds, gyre-like folds, also called as Sézary cells, seen in Sézary syndrome because of leukemic dissemination of mycosis fungoides. And here's the classic example of Portreous microabscess that is seen in patients with mycosis fungoides. Portreous microabscess. And you know, Sézary patients, most of them are going to present like this, erythroderma, diffuse erythroderma. And if it's mycosis fungoides, you're going to have the characteristic evolution, isn't it? Initially, you will have patch stage, then you're going to have plaque stage, then you can have tumor stage, and finally you can have something called as erythroderma, which is something that we've discussed already. So with this, I'm going to complete the chapter on lymphomas. It's a lot of information, I know, but it's an essential information. That's why I summarized everything at the end very nicely. So I think this is enough to answer any question in any exam for that matters. Thank you very much. See you in the next section.